Chapter 8, joints. So when we're going to start talking about this section, we're now going to build on the complexity of the skeletal system and talk about the connection between all of our bones. So that's going to be called this joint. Another term you'll see is going to be called articulations or articulation. And that essentially is just going to be whenever there's going to be a bone connected to another bone, it will be called an articulation. So if you see the term disarticulated, where it's with this in front of the word of articulation, that means that the bone is just outside of the skeleton and you're just looking at the bone itself. So joints are also going to be called an articulation, and that's where two bones are going to meet. And as we go through, we're going to classify a couple different ways all of our joints. So there's two classifications. The first one is going to be structural, and the second is going to be functional. So as we go through these two classifications, we're going to go more in depth with these. We'll talk through these specifics. So as we start, we're going to go through and let's just review our structural classifications of our joints. So we've got two types. When we're talking about the structural classification, we're talking about what is it actually going to be made up of? How is the joint formed? What's the structure of it? So this is going to be based on what binds the bones together and how the joint is actually formed. There are three types for a structural classification. Fibrous. A fibrous joint means that it's connected by fibrous tissue. A cartilaginous joint means it's connected by cartilage. And a synovial joint is where we're actually going to spend the most time talking about in this chapter. So synovial joint is going to be slightly different. You can also classify a joint based on its functional classification. What is the joint able to do? How does it actually work? So this is going to be the movement, what it does. With a functional classification, there are three types, and these are very easy to confuse. So it helps to say them out loud. When we're talking about a joint movement, essentially we're looking at no movement, a little bit of movement, or a lot of movement. So a synarthrosis is going to be immobile, no movement. Where you have an amphiarthrosis, and if you think about an amphibian, where it was half on water, half on land, that is going to be some movement or slightly movable. And then the last one is going to be a diarthrosis. And this is going to be freely movable. Essentially, it has the ability to have full rotation, do whatever it wants. These are our joints that are fully movable. So you do need to know these three of each, and we're going to go into specifics on all of these. So we're going to start with our classification for our structural joints. So the first one we're going to have is a fibrous joint, and a fibrous joint is going to be made up of exactly what's in the name. So these are going to be connected by dense fibrous connective tissue. What's important about these is that there is no joint cavity. And what we mean by joint cavity is that the bone is going to connect directly to the bone. They are actually going to touch each other and then be connected through a fibrous connective tissue. There is not going to be a space between them with essentially a cavity of some kind. When we get to synovial, it'll make a little bit more sense. But this is the primary importance of a fibrous, is connected by connective tissue, fibrous connective tissue, and no joint cavity. And most of these are going to be synarthrosis. So most are going to not be movable. So most are going to fall into this category of a functional classification as a synarthrosis. There are three types that you do need to know. We're not going to go super in depth with these three types for this chapter, but we're just going to review what they are. First type is going to be a suture. An example of a suture is going to be the joints between the bones of the skull. So we're going to have our temporal bone connected to our frontal bone right over on the side of the forehead, and that's going to be connected through a joint. Through a suture joint. These are really important. They're found in the skull, and they're going to allow for growth during youth, but then they will actually fuse. And so when they've actually fused and they are essentially in the adult, they have a different name. They are going to be called syncytiosis. So just don't get that confused with a synarthrosis, but sutures will become synostosis. Then the second one we're going to have, here's an example of your fibrous joint, so you can see those. The second type of fibrous joint is going to be a syndesmosis. These are all 15-letter words, and they're all very, very similar. A syndesmosis is going to be connected by ligaments. So this is also an example of a fibrous joint, so there's no joint cavity. So this example is going to be found in areas where there's going to be little or no movement. So they are connected with a ligament, and that ligament is going to allow for little to no movement. So with these joints, an example of this type is going to be the joints that are areas where we need a little bit, but we actually don't need a lot of movement. So when you have your radius connected to your ulna, that is an example of a syndesmosis. So these little to no movement will actually vary on the length of the fiber. So this will actually be dependent on the fiber length. So if there is a long fiber length, they will have a lot of movement, more movement, and if there's not a lot of length to the fibers, they will have no movement. So the example of the radius and the ulna is, or tibia and fibia, is another example. If here's one bone and here's the second bone, this particular one is connecting these guys right here. So you can see that right there. Okay, so then the third example of a fibrous joint is a gammophose. This is going to be the peg in the socket. There's only one really good example of this type of bone, and this is going to be a tooth in the jaw. So with a gammophose, it's going to be the teeth in these sockets. It's because it's connected also by a ligament. So you can see how this is actually going to be the peg, and that's the socket. So that's an example of a fibrous joint. Moving on to the next type of joint, we had our cartilaginous, and these are all connected by cartilage tissue. So these are all going to be very similar to fibrous, with that connection being framed around the same classification of tissue, and these are also going to have no joint cavity. So that's also important. There's no space and no fluid in between these areas. These are also not going to be highly movable. They kind of fall into that framework of little to no movement as well. And there are two types that we're going to talk through. So there are three types of fibrous. There are two types of cartilaginous. And just start keeping them straight. Synchondrosis. So with our first type of cartilaginous, with our synchondrosis, what we're actually looking at, if I can spell it right, what we're actually talking about with these synchondrosis is that it's connected by hyaline cartilage. So that's the type of cartilage that will be connecting these particular bones of this joint. And so this hyaline cartilage, as it's connecting these guys, it will make it immobile. So these are all going to be under the classification of a synarthrosis. So don't get confused with why a synchondrosis is a synarthrosis. Remember, synarthrosis is the functional classification. It is little to no movement. So an example, there's really two examples that we're going to talk about with our synchondrosis. And these are in the epiphyseal plate of a long bone in children. That is where we will see a synchondrosis. And then another example is going to be between the first rib of the sternum and the mandibrium. So this is one, but then this is the biggest one that we'll actually have in our bodies. And then the second type of cartilaginous is a symphysis. A symphysis is going to be fibrocartilage. So it kind of is going to fall into the middle world of fibrous and cartilage. And so this is going to be a symphysis joint. What's happening with this is these are going to be slightly movable joints. So that means these are going to be amphiarthrosis. So they are slightly movable. Some examples of this that are really commonplace are going to be your intervertebral joints. So in between all of your vertebrae, all the way down your backbone, will be a joint connecting all of those, will be considered this type of symphysis joint. And then also your pubic symphysis, the connection between your coaxial bones in the pubic region, is connected with this type of joint. So you can see it there, and then these guys. But the purpose of the focus of really today is going to be all the joints that do more movement. So we're going to now, essentially for the rest of the chapter, talk about synovial joints. And these are the prime important, what we think about when you talk about a joint, it's going to be a synovial joint. These are different because these are actually going to be all separated. So the bone connected to another bone is all separated by a fluid-filled cavity. So there is enough space between all of the bones to contain a fluid. All synovial joints are going to be diarthrosis. All are freely movable. So they can rotate, they can move, they can adduct. They will all have the ability to go through all of the planes of motion. And essentially, these are going to be all of our limb joints. So these are going to be found everywhere we need large skeletal movements. So all of our limb joints will be this. And there are some general features that all synovial joints will have. So these 6 general features right here are what we're going to talk about in the next couple of slides. So these 6 features, first one, this is going to be, now remember, all limb joints. There are going to be some 6 general features to a synovial joint. Not a joint, but a synovial joint. Okay, the first feature is going to be something called articular cartilage. And what we mean by articular cartilage is that at the end of every bone that is involved with this, there will be cartilage covering the articulation or the end. So if you're looking at, let's say, the bones between your humerus and your tibia, if these are on the side, there's going to be articular cartilage that is covering this end and this end. So that is going to be hyaline cartilage that's going to prevent crushing on the ends of the bones. The second general feature is going to be the fact that there is a cavity. So if I'm going to have my bone and my bone, here we go, we have an articulation. Now what we're talking about is that there's going to be some sort of space between them that's going to create a cavity of some kind. And it is going to then be what we're talking about for the rest of these kind of areas. Okay, the third characteristic is going to be that there is a articular capsule around this cavity. So if we have this lovely little cavity right here, what we're talking about is that this articular capsule will actually surround this cavity and give it essentially a framework. So we're going to have a capsule that goes all the way around it. This capsule is going to be 2 layers. So I just drew it on our example right here, but there's going to be 2 layers. There's going to be an internal layer, which is going to be this green, and that's going to be your synovial membrane. This synovial membrane, or this green layer that I just drew, is going to be the one that makes the fluid that will then be found inside this joint capsule. And then the next section, or the next part that your joint capsule will have, will be the exterior, because it's 2 layers. So you have an internal and an external. So there will be this outside layer to this capsule. And this outside layer is going to be the external layer. The external is going to be highlighted as the red, and this is going to be connective tissue. So essentially, it's a dense, irregular connective tissue, which does not allow for tension, which does not allow for twisting, which is really, really good for maintaining the integrity and the structure. So you're going to have this capsule that's going to surround this cavity. The capsule is 2 layers. The outside layer is a dense connective tissue. The inside layer is the synovial membrane that will then make synovial fluid. So that's characteristic. Okay, so now the fourth characteristic we've kind of already referenced. There will be something called synovial fluid. So within here's our joint. We have our capsule with layer 1. Here's our capsule with layer 2. Layer 1 inside is the part that actually makes the synovial fluid. What we mean by that is he will actually be producing liquid, and this liquid will fill this inside space. So the capsule up here and the cavity that we talked about is just the space in between. But the synovial fluid will actually be liquid between our bones. So what's really important about these is that these are going to lubricate the ends of our bones, so we actually do not get friction when our bones move. So this is going to really, really help with lubricating and nourishing that articular cartilage in order to give it the nutrients that it needs. And then it will also contain some phagocytotic cells inside in order to clean out the joint and just keep it healthy. But it's mainly going to be kind of a liquid-based fluid. Sorry, a water-based fluid. And then the next area we're going to have in our synovial joint is that there are going to be reinforcing ligaments. And what we mean with these reinforcing ligaments is that with this joint, you essentially have 2 bones connected, tissue surrounding some liquid that's holding those bones together. That's awesome, but that's not going to be super strong. So that means around our actual joint itself, there is going to be ligaments that are going to hold everything in place. So we will have ligaments connecting from all around our sections, holding everything in place. There's going to be different types. You'll have one that's capsular, that's going to be part of the fibrous layer. You'll have the extracapsular, which will be this outside, and then you'll have an intracapsular. So when we see the full picture, we'll talk through all of these pieces one more time. And then the last general characteristic of a synovial joint is that every single joint will have nerve and blood supply. All of them will be able to detect pain because there's a nerve, and everything will be able to have access to adequate blood supply. So this is really, really important for our bodies to be able to monitor our position and our stretch, but also to be able to keep the tissues itself healthy, give it all the nutrients, take away all the waste, and just make sure that it is a thriving, living tissue. Okay, so looking at all of that, I drew my structure horizontal, but this is a vertical one, but just to kind of highlight the characteristics. Here is our bone. Here is our bone ends. All the way around, you can see we've got this blue capsule that's all the way around. And then inside this, there's going to be our 2 layers of our articular capsule. Here's our fibrous inner layer and our synovial membrane that we'll actually have. Here is going to be the ligament that is holding it in place. So this guy is going to be all the way around the whole thing, holding it in place. And then inside this area, you will have that liquid that is going to be the synovial, essentially, liquid all the way inside. So that's kind of giving you an idea of how all of this works. So this is a simplified bone, but this is the general structure. So all of our synovial joints will have these. Some other characteristics of synovial joints is that they will have fatty pads, essentially depending on the movement needed in each joint. There may be additional cushioning made up of a layer of fat in order to have there not be increased friction or tension. And then some joints are going to have an articular disc or a meniscus, and essentially these will help the rough edges of one bone fit better with the rough edges of another bone and kind of give them a little bit of a better surface to separate that, and so it fits the bone ends better. So as we're going with that, we're not going to cover bursa and tendon sheaths, but you can kind of see how here's a synovial joint with our articular cartilage right here. Our joint cavity is this space in the middle, and then here is going to be our essentially the articular capsule holding it in place. This is our humerus, so this is going to be the shoulder joint. When you're looking at this, there's a bunch of other things. So we've got the bursa. There's going to actually be, it's this section in the middle that will be covering these tissues, so you can see how complex this is. We're not going to go through for the lecture and speak to the specific involving all of these joints. You do need to know the general structure of a synovial joint, but you don't necessarily need to be able to do the details of labeling an individual joint like this. But you can drive in and see a little bit easier. Okay, so the synovial joints are one bone end connected to another bone end with a space in the middle, with membrane around it, a capsule around it, filled with liquid, and then ligaments holding it in place. How in the world is this stable? So there's a couple different reasons that and things that will influence the synovial joint stability. So there's a couple different things that will make whether or not this synovial joint is super, super strong or whether or not it needs a little bit more help being stable. So there are 3 factors that will help with your joint stability. First one is going to be the shape of the articular surface. So how the actual bone ends are formed in order to connect to another bone end. If it is going to be something like this, there's only this much space for them to connect. If there is something like a ball in a socket, there's a lot more surface area. So the shape of the articular surface and how they actually connect will lead to stability. The one that's more stable has the more surface area. So this one would be the more stable. Another thing that helps with joint stability would be the ligaments themselves, the location and number, how they're actually wrapped around the bones and how many of them there actually are. So the more ligaments, obviously, the stronger joint. The more they wrap around, the stronger the joint. And so then something else that will affect joint stability is something that is called muscle tone. And we'll reference this again when we get to skeletal muscles and go through chapter 9. But muscle tone will actually keep the tendons and will keep your muscle taut. So this is why you will have your bone who will actually be in this plane, because there is a tendon that is keeping those bones at this particular essentially degree. Whereas if you don't have these tendons doing what you do, here's your bone, here's your other bone. Essentially, these tendons have not done your job. You now have this and this. That's not necessarily what you want. So muscle tone is going to keep the ligaments taut as they cross the joints. This is probably the most important part of maintaining the stability of a synovial joint. So this is really important with shoulder and knee and your foot, but this is probably the most important one you need to know. So here's some examples of some classifications. You'll see that synovial joints are everywhere. And so now we're getting into some of the things that are probably a little bit more common sense. So we're just going to run through these topics. So with synovial joints, remember, all muscles, every muscle we're going to talk about in the next couple of chapters, let's rephrase that, all skeletal muscles attach to bone. And as they attach to these bones, they have to connect at least 2 parts. So you are always going to essentially think of a skeletal muscle as something like this. If this is my skeletal muscle, there is always going to be one place and a second place. Both of these will have to attach to a bone at some point. These 2 places where the skeletal muscle will attach will have 2 different names. An origin, when you have one of these attachments called the origin, it's going to be the immobile bone. The insertion is going to be the movable bone. So what that actually means is that movable and immovable bone are going to be kind of a different phrase. So let's say we have a lovely little dude right here, and we are going to ask him to flex this arm. So he's a cute little 4-year-old, and we've asked him to flex this arm. If we look at this particular structure of the arm, let's blow this up. Cool. So in order to stretch your arm, actually, he goes like this to, well, let's just restart that over. Okay, asked an adorable little 4-year-old to stretch his arm. So he starts by sticking his arm straight out, right? And then what he does is he will then bend one of his arms, or his right arm, into this. And we've asked him to flex this arm. This arm will move up. Okay, so to do that, there are skeletal muscles that are going to be doing that. The skeletal muscles are attached to bone. So let's say this cute little 4-year-old has the muscle that we're talking about is going to be right here. Whoa, that's way too thick. Okay, let's try that again. He's connected right here. So he's got one connection here and one connection here. Because it's a skeletal muscle, there has to be two connections. You guys good with that? Okay. So when you're looking at this bone right here, remember his elbow is right there. So with this skeleton, this bone right here did not move, right? That stayed the same. The part that moved would be his radius and his ulna. So the radius and the ulna went this way. So your humerus did not move, but your radius and your ulna did move. That's what we're talking about with movable and immovable bone. Which one is making the action in the skeleton, and which muscle is attached to the bone that has made that action move. So that means right here, looking at this lovely little 4-year-old who's just flexed his arm, this right here is the immovable arm. So that means this is the origin, a connection of that muscle. This right here moved. So that means this is the insertion. A way I like to think about it, and I have no idea if it's helpful, but I like to think about it from the sense of like when you move throughout your life, you have essentially inserted your life into somewhere else around the world. But wherever you were born, your origin, your place of birth, does not ever change. So your origin, or the place that you started your life, will always be the same. It does not move. But you can insert yourself and you can move around in life and go to different places, but you'll never change your place of birth or your origin. I don't know if that's helpful, but that's how I like to think about it. So this movable insertion and origin is a very important term that we'll highlight again, and you'll see a lot in the muscular system. Okay, so we're using our muscles. They are connected to our bones, and now we're moving things. So there's a bunch of movements that are allowed by your synovial joints. These movements essentially are going to be the range of motion. So the range of motion movements, we are going to have some that are going to be non-axial, which are considered sliding movements. We should have a picture. I guess we only have the gliding ones. Okay. Non-axial are going to be sliding movements. So that would be you have a bone, and they can slide this way. Sliding movement. You can have a uniaxial, which the movement can only happen in one plane. So up, down. Biaxial, which means it can only move in two planes, so you can go up, down, or side to side. Or multi-axial, which means you can do essentially lots of planes, at least 3 planes. The general types of movements are gliding, angular, and rotation, and we're going to talk through these. So these are going to be movement types. First one is going to be gliding movements. When we're doing gliding movements, we are talking about one flat bone sliding over another flat bone. So up here in my example of a non-axial slipping movements, that's exactly what this is talking about. They're only essentially sliding over each other. So with a gliding movement, some examples of these are actually going to be bones in between your intercarpals, so the bones in your hand, specifically in your wrist, your intertarsal, specifically in your ankle, and between the articular process of your vertebrae. And essentially you're doing only this movement where these bones are just moving one direction, kind of side by side. The bones in your wrist are doing this when you essentially move your, wave your hand. Okay, the next type is going to be angular movements. And this is where you are going to be increasing or decreasing the angle of the joint. So with our cute little 4-year-old up there who went from here's his arm, elbow, here's his hand, he essentially, here's his body. What he did was he moved this arm up. So he went from 180 and then he moved it so that it was, here's his elbow, boop, here he goes. Now this is 90 degrees. So he has decreased the angle of the joint, or you could do the opposite. He could flex his arm and then return it back to normal, and he could decrease the angle of the joint. So that's essentially what we're talking about with angular movements. You're talking about the joint or the angle between two bones. It's always going to be usually along the sagittal plane. And flexion and extension is what most of us talk about or have heard about. So if we're our cute little 4-year-old right here, he is actually flexing his arm. That's the technical term is flexion is going to be decreasing, whereas extension is increasing the angle of the joint. You also have something called hyperextension, which means that it goes beyond its normal anatomical position. So our cute little 4-year-old who's got his arm out at 180, that is actually the normal anatomical position. If he had a little bit of lower tone and his joints was not at 180, but he was more like at 210, where his elbow popped up, that would be hyperextension. So you can see this with people who put their arms out in front of them, one elbow pops up, or you can see this with people who are standing straight, and rather than having their legs be straight with their knees right under their hips, their knees will tuck back and they kind of get that bow-legged look. So that would be hyperextension. So you can see how with flexion and extension, here's our neutral position of our head. If we move it forward, we decrease the angle of the joint. That's flexion. If we move it back, we have increased the angle of the joint. That's extension. So you can kind of see how that will be, this is at all of our synovial joints. So even your arms and your legs. If you are interested in the world of physical therapy, you will live in this world. You will live in chapter 7, 8, and 9. So flexion, extension, and how joints move will be super, super important. There's a couple other types of angular movements that you can have. Flexion and extension. You can also have adduction and abduction. These go together. One is toward the midline. One is away from the midline. So if you are going toward the midline, what you're doing is you are moving something in. You essentially are going to adduct. You are adding to the midline. If you are going to move something away, you are going to abduct. So I like to do adding as adding to the middle of the body. You're adducting. An example of this is when you clap your hands. When you clap, you move your hands towards the middle of your body. You're adducting them. When you release the clap, you move your hands away. That is an abduction. And then you also have circumduction, which essentially is going to be when you move all flexion, abduction, and extension and adduction all at the same time. You do everything we've talked about, but the best way to do this is you're describing, it's the cone in space. So you've got your arm right here, and what you're doing is you're rotating it around. That requires you to move it toward the midline and away from the midline. It requires you to increase and decrease this joint. All of that is flexion, extension, adduction, and abduction. Okay, so the next section is going to be rotation. These are still those, we did our gliding, our angular, and now we're doing rotation. Rotation is going to be when you are moving it around an axis. When you are moving something around an axis, you are essentially rotating it. So this is going to be what we think about when we think about our rotating your head and you're rotating your C1 and your C2, you are rotating your head, but what you're actually doing is allowing the connection between C1 vertebrae and C2 vertebrae to actually be able to move around its axis. So there's a couple other cool special movements that can happen with our synovial joints. So special movements are going to be supination and pronation, and this is the radius or the ulna, and there should be some pictures. Yeah. So supination and pronation is going to be specific to the arm. And so when you have supination and pronation, essentially supination is when palms are going to face anterior. So this is going to be palm up or soup, whereas pronation will be palm down. So moving between palm up and palm down is going from supination to pronation. So you can see that right here. Supination, again, is palm up. Essentially, you can cup soup in your hand. Sup. That's how I think of that. Whereas then you have dorsiflexion and plantar flexion. So this is going to be specific to the foot. Dorsiflexion is when you're going to actually have your toes point to your shin. So this is when you're essentially walking on your heels. So your toes will bend towards the shin, or you're walking on your heels. Where if you have plantar flexion, this is going to be a ballerina. This is pointing your toes. You're walking on your toes. So here we go. So this one right here, you're going to go up, dorsiflexion, pointing your toes, down, plantar flexion. And then a couple other special movements. These are also going to be in the foot specifically, or inversion and eversion is at least. So this is going to be in the foot. When you have inversion, you're going to take your foot and face the inside sole of your foot towards the middle of the body. Whereas if you have eversion, you'll take the sole of your foot and move it so it rotates laterally. So here's the midline of the body. This part is going to be the actual, this is not the midline of the body, this is the line of the foot, but the midline is going to be right here. And I can tell that because here's my big toe. So if you go towards the midline of the body, inversion. If you go away from it, eversion. So you'll notice that all of these have a opposite kind of movement. Okay, and then protraction and retraction are specifically going to be seen in the mandible is the biggest one. Protraction is when the mandible, you stick the bottom, mandible is the bottom part of your jaw out. Retraction is where you pull that mandible back towards your neck. So protraction, you've stuck it out. Retraction, you've moved it in. And then you've a couple more. You've got elevation and depression. So this is going to, you can do this in the mandible. You can also do this in the shoulder. So if elevate, just like it says in the name, it's going to be lifting the body and it's going to be moving it up. So this, you could be closing your mouth or you could be raising your shoulders. Either one, you are moving that joint up. The opposite is going to be depression, where you're moving the joint down. So this would be opening your jaw. Moved it down, or this could be bringing your shoulders back down. And then one that's super important for humans that's a little bit different, the opposition. And opposition is directly related to the thumb. And this essentially is what makes us different, or primates different than other animals, is this opposition ability. So you can actually take your thumb and touch every single one of your other fingers in order to do a gripping movement. If you did not have your thumb, it would be hard. You would not be able to actually sustain a strong grip, which is what makes primates and humans different than the rest of the animal kingdom. So this oppositional movement is really cool. So you can see that right there. Okay, here's an example of all the limbs, or all of the movements that we've just talked about. So with the next part, this is going to be where we're just kind of going to hit the highlights for these synovial joints. So there are going to be specific types of synovial joints that you'll have. So the first one, what we just talked about, was the movements. These are going to be the types. So this is going to be essentially what the surface of the bones looks like. So these are going to be just really easy, so we're just going to glide on through them. You're going to have the plane joint. The plane is essentially going to be where you have the bone, it's a flat surface. You can see that right there. Then you're going to have a hinge joint, and a hinge essentially is going to be where you have created this. It's not the ball and socket, but it's kind of like a mortar and pestle, where there's going to be some sort of hinge, but it's not a full ball, but it has that same feel. Example, this is your humerus and your ulna. Then another type of joint connection you're going to have based on the articular surface is going to be a pivot joint. This kind of is like a door frame. There's going to be this structure right here where the joints can where the bones can pivot around the joint. Radius in your ulna, the lateral side of how they connect will be that. And then the next one is going to be a condyloid. So this is going to be a little bit similar to a ball and socket, but not quite a ball and socket. So rather than a ball, it will be essentially an oval shape for that articular surface. So it's not quite a ball, but it is an oval. It's a little bit kind of like a shallower version, but it is a separate type of connection. Then you can have a saddle joint, and a saddle joint is essentially what it talks about. It goes around the joint. So this will be one bone will have this, one bone will have this. So it allows for them to essentially connect, kind of like sitting on a saddle. And then the biggest one that we probably all have heard of is the ball and socket. This is the most stable because you've got the ends of your bone, and then you've got a pretty full connected joint area that is being covered around it. So this is the most stable of the joints because the surface area of the bone connecting to the bone is the largest. Okay, so moving on to the areas that we're going to have in our body that are selected synovial joints. Selected synovial joints. So we're going to take essentially only a few synovial joints in our body. So as we said, most of the joints of your limbs are synovial, but rather than go through every single joint, we're just going to hit the 5 main ones. So all of the ones that we're going to talk about have the same general features, but they all have unique features that we're going to talk about. So there's 5 main joints. So out of these 5, we're just going to briefly, quickly kind of run through the feature that you need to know about each one. 5 main ones. The first one is going to be the TMJ, otherwise known as the temporomandibular joint. The temporomandibular joint is connecting the temporal bone and the mandible bone. So it's going to be the jaw. This is a hinge joint, and this is going to be one of the areas where you're going to have the most easily dislocated joint in the body. So the way these are connected make it the most easily dislocated type of joint. That's really what we're just going to focus on about it. So we're just going to do the characteristics of each one. So you can see this joint right here. We're talking about that right there, the connection between the temporal bone and the mandible. Temporomandibular joint. Okay. The next section, it's the most common because it's super, super shallow. The next thing we're going to talk about is the shoulder joint. So we've got the temporomandibular, then we've got the shoulder joint. And what's interesting about the shoulder joint is that this is going to be the most freely moving. You have the most range of motion with this synovial joint. So this is the one that's most freely moving. It is a ball in the socket. It's not the main ball in the socket, but it is a ball in the socket. And it's going to essentially be the one that allows you to rotate around the most planes of motion. So this is the structure. We're not going to go through the details. I'm not going to ask you to name all of these pieces, just know the general characteristics. So we're not going to go into the ligaments or any of these either. Okay, So we've got our shoulder, and if you are interested in anything rotator cuff, if you've ever had one of those tear, feel free to read, but we're just going to focus on the joint itself. Okay, then the third joint is going to be the elbow joint. So we've so far got the TMJ, temporomandibular, the shoulder, and now we're going to have your elbow joint. So this is actually just one of our main synovial joints. It's the one that articulates the radius and the ulna to the humerus. So we've got the connection of 3 joints. And you can see how here, we've got bone 1, bone 2, and bone 3 all connecting at this joint. Okay, and then the next one we're going to talk about is the hip joint. And with our hip, this is going to be the one that is the most stable joint out of all of them. So this is going to have the greatest stability due to the ball and socket feature that it has. So this guy right here is the deepest and it is the most stable, but it is only going to have some range of motion, which is why you can move your arm more, but not quite move your hip in the same movements. So you can see all of these fun things. And then the last one we're going to talk about is going to be the knee. And the knee is going to actually be the largest joint and the most complex joint in the entire body. I would have said hip thinking about it, but it is actually going to be the knee. The knee is the largest and most complex joint we have in the body. That's because we are connecting not only the femur, but you're connecting it to the patella, and you're also connecting it to the tibia, which is then connected to the fibula. But the fibula and the femur do not actually connect. So essentially, it's a bunch of different small mini joints made up into the larger knee joint. So it's really the most complex one. If you've ever had an ACL tear is the anterior cruciate ligament, and essentially it means that you have torn that. And so this ACL, or the anterior cruciate ligament, connects the back of the femur to the front of the tibia. And if you shear that, essentially that is what the biggest challenge is going to have with an ACL, is it does require surgery to sew it back together. So that's where an ACL is, if you've ever heard or personally had the anterior cruciate ligament, or the ACL damaged or hurt. Okay, so this is the knee joint. Again, we're not going to go into the details of the ligaments or the bursas, so you do not need to know these specific details, but you do need to know it's the largest and the most complex. So we're hitting the highlights on all of the synovial joints. We're just going to hit the highlights. Feel free to read all of the rest. Okay, the next section is going to be common joint disorders. What are some common injuries and some common things that can go wrong? So as we get into these sections in these chapters, we're now talking about how things can go wrong. So in the world of joints, first thing that can go wrong is you can actually tear the cartilage. If you tear the cartilage, it can be for any reason. It can be for compression, it can be for stress, it can be because you move the wrong way, but you can have these cartilage tears. Essentially what happens is these particular breaks between a cartilage does not repair itself. So cartilage tears are not able to repair themselves. They do require surgery in order to fix and reconnect the 2 ends of the broken cartilage. So just whenever you see someone with a ligament or a tendon tear, it will require surgery to fix. Another joint, a common joint disorder, is going to be a sprain. Not a strain, but a sprain. A sprain is where it's going to be the reinforcing ligaments. So it's the ligament itself is usually going to be stretched, and it's painful. It may also be torn. So these are the reinforcing ligaments that go around the synovial joint. It could be stretched or torn. So common places you'll find these are ankle, knee, and lumbar, where the joints can easily move, where the ligament, the articular ligament keeping it in place, will actually be stretched. You may have some partial tears, and because they're partial, they may not require surgery, but they are very slow to actually heal because these particular ligaments do not have a lot of blood supply, so poor vascularization. So if it's torn completely, they need to be sewn together through surgery, graft them together, or essentially just immobilize the joint and hope that they heal over time. So dislocation is going to be different than a sprain. So dislocation is about the actual bone, whereas a sprain is about the ligament holding the bone in place. So with a dislocation, what is actually happening is the bones are forced out of their normal alignment. So they are not where they need to be. They've been moved essentially out of socket. So they usually come with all of the above sprains, all those pieces, but it's the bone itself. Usually can happen quite frequently in any kind of sport. And when it says must be reduced to treat, we have to make sure that the inflammation in the area has been relieved so that way the bones can be put back together the correct way. When you have something called a subluxation, that is a partial dislocation. So another word for dislocation is luxation. Subluxation is just partially out of alignment. If you've ever heard of bursitis, we skipped over and we're not going to cover the bursa that are found in synovial joints, but that is going to be an inflammation of the bursa that's found in those joints. So that can be a painful kind of condition. And tendinitis is the same way. So it's inflammation of the actual tendon holding the bones in place. So there's going to be more inflammatory type things. And then we're talking the last three things we're going to talk, I think it's the three, but the last couple areas we're going to talk about is we're talking about articulation. One of the conditions or disorders that can happen with articulations is going to be arthritis. So it's not just a condition of the bone, but it is a condition of the bone connecting to other bones. So arthritis will live in this world. And there is a bunch of different types of arthritis. So arthritis is a general name for anything that's going to be damage or disease to a bone. There's over 100 different types of arthritis. We're going to talk through the three top ones. It is the most widespread crippling disease in the US, and the symptoms of it are usually pain, stiffness, and swelling of the actual joint. So arthritis is a joint condition. And there's chronic forms that we're going to talk about. These are the three we're going to talk about real quick. So the first type of arthritis is going to be osteoarthritis. Osteoarthritis, or OA, essentially is going to be the one that you think of when you think of arthritis. It's the most common. This is the irreversible or the degenerative, the normal old age wear and tear arthritis. So this is what you think of when you think of that by the time you get later up in life, by age 85, most people have had diagnosis of arthritis. This is going to be the one it's going to be talking about. So what happens with osteoarthritis is this particular steps right here. So with osteoarthritis, what is happening is that it may be due to the bone articular cartilage. So the articular cartilage that is covering the ends of the bones is being destroyed, but not yet replaced. So you could be destroying and taking care of more of that, but you haven't actually replaced it. So it is going to be wear and tear on the bone ends. The second type, this is normal aging process, some more information about it. The second type is going to be rheumatoid arthritis. This is another pretty common type of arthritis, but it's not old age. So this is rheumatoid arthritis. this is going to be chronic and it's inflammatory and it is an autoimmune. So this is where you're going to have the same characteristics of all of the other of osteoarthritis, but what's happening is that your immune system is attacking essentially yourself. That's what autoimmune means. So this is going to be the same thing where you're talking about that articulation inside the synovial capsule, but it's actually going to be broken down because your system is attacking itself. This occurs usually at a younger age than osteoarthritis, so that can sometimes help with the specific diagnoses of it. Okay, so how does rheumatoid arthritis work? So it's not just breaking down the articular cartilage and not replacing it like osteoarthritis. This is going to be inflammation of the membrane of the joint. So you're going to start with rheumatoid arthritis. It will start with actual inflammation. And what will then happen with this inflammation, you will essentially have inflammatory blood cells that come release, and they will actually start to destroy tissue. So your inflammation will actually try to be healed. And as that happens, you will essentially accumulate fluid in that joint. And as you accumulate fluid in that joint, the joint will then swell. As the joint swells, you will get a thicker membrane that will then allow the because you need to create more synovial fluid. So you will have a thicker synovial membrane because it will cling to that articular cartilage. So as you get a thicker synovial membrane, now what will happen with this is these will actually put together and form a scar tissue because this thicker synovial membrane has started to erode. And as it starts to erode, it will form scar tissue and it will connect the articulating bones in. So the end result of this is it will connect the bone ends. And it does it because this thicker synovial membrane will start to erode and form scar tissue. But looking at this guy right here, so these are actually, rather than here's a bone, here's a bone, here's a bone, they have all essentially been fused together, bone on bone. Okay, the last two conditions we're going to talk about. When we're talking about, you could hear gout. Gout is considered a type of arthritis or gouty arthritis. But gout is the shorthand term that we use in pretty much everyday language. And this is going to be the deposit of uric acid crystal. So rather than being a waste product that you should have that leaves your system in your urine, you'll have a buildup of uric acid crystals in your joints. And what you then have when you have this buildup of these crystals in your joints, you will get inflammation. For some reason, it's typically in men, and for some reason, it typically affects the big toe first. So if someone's complaining about their big toe and they're having issues and they're a man and they're middle-aged, this might be a good condition to look at to see what's going on with gouty arthritis. And then the last one that we're going to cover is Lyme disease. So Lyme disease is considered a joint disorder. So this is caused by, if you've ever lived in the South, it was be careful not to get bit by a tick. Lyme disease is caused by a bacteria that comes through and is transmitted in tick bites. This is going to lead to joint pain and can ultimately lead to arthritis. But Lyme disease is something that's talked a lot about in the South because of ticks. And it's going to be specifically related to not just the bite, but it's the bacteria that is carried, then that bacteria can cause inflammation and affect your joints. So that's really what we're going to focus on for chapter 8 is the overarching biggest concept is the synovial joints, the general structures, the main types, the characteristics of those main types, and then the structural and functional classification of just the overall joints. So we're not going into the super nitty gritty. There's not going to be a picture. You're not going to need to label all these pieces except for the general structures of a synovial joint. The rest of them will be covered in more of a lab class. So that will be it for chapter 8.